Hi, my name is Nader and I'm one of the SHOs in General Surgery at Queen's Hospital. Today I'm doing a talk on the management of COVID-19 for the non-ICU trained doctors. The recent COVID-19 pandemic has put a significant strain on healthcare systems across the globe. For the NHS, this has meant an urgent restructuring of how we deliver care, and for the staff, this may involve redeployment to work in different teams and in less familiar environments. The aim of this talk is to support and prepare staff going through this transition. While there are many aspects of this pandemic, be it economic, political, or public health, I will try only to focus on the clinical aspects. Having said that, I will start with a brief look at the etiology and pathophysiology to contextualize this disease and better understand aspects of clinical management. Cases of severe respiratory distress started in Wuhan, China in December 2019 with an unknown etiology. Subsequently, on the 7th of January 2020, a novel coronavirus was identified as the causative agent. This is a positive sense, single-stranded RNA virus, which is a beta subtype according to its genotype. Like other beta subtypes, SARS and MERS, it is highly pathogenic. It appears to enter type 2 pneumocytes via the ACE2 enzyme, which itself is expressed more so in men and varies in different races, possibly explaining different morbidity and mortalities in these groups. There then follows 2 stages of illness. There is an initial, replicating stage where viral titers increase and the innate immune response fails to contain the infection. This stage is typically associated with a mild clinical picture. There then follows the adaptive immune phase, which may lower the viral load, but is associated with an increased inflammatory response and may show clinical deterioration. Importantly, the initial symptom severity does not necessarily correlate with disease progression. Now, in terms of the pathophysiology of severe disease, this typically involves development of ARDS, with histology also demonstrating direct virus-induced pneumocyte damage rather than hyperinflammatory damage alone. Nevertheless, the presence of a so-called cytokine storm may contribute to clinical features of sepsis with or without shock. This can be monitored with rising acute phase proteins, which may correlate with disease severity. Now, before we go into more detail on the assessment and management of COVID-19 patients, I guess we need a bit of a disclaimer. The contents of this presentation are based on NHS England guidelines and supported by some recent research evidence, both national and international. That is to say that local practice at Queen's may vary, and indeed practice between clinicians may vary. This talk aims to ensure your practice is guided by recent evidence and national guidelines, as well as introduce you to some less familiar aspects of clinical medicine, but your practice may be fine-tuned by the trust and the responsible consultant. Now, when assessing patients with suspected or confirmed COVID-19, we have to protect ourselves as staff, as well as other patients and the surrounding environment. Where possible, patients should be triaged in isolation in well-ventilated rooms and assessed in a side room. Priority for negative pressure rooms should be given if any aerosol generating procedure is carried out. Decontamination of equipment and the environment should be performed using a detergent or disinfectant with 1000 parts per million of chlorine, and strict hand hygiene should be adhered to. With regards to PPE, at present, Public Health England recommend the use of fluid-resistant surgical masks and single-use gown and gloves when assessing or treating suspected or confirmed COVID-19 patients. Eye protection should also be used if contamination to the face with blood or bodily fluids is anticipated. NHS England recommend the use of FFP3 masks only when performing an aerosol generating procedure on suspected or confirmed cases. As the pandemic develops, a history of contact with known or suspected COVID-19 patients or a travel history has become less important in patient workup, and initial risk scoring systems have become less useful as exposure to the virus is high. Therefore, anyone presenting with clinical or radiological features of pneumonia with a history of influenza-like illness or with ARDS should be considered as a possible case. Patients can largely be split into three groups. Those with mild illness who are previously healthy are likely to be discharged. They must be advised to follow government guidelines for isolation and must be safety netted for worsening or new symptoms for themselves and for their social contacts. This should be carefully documented in the notes. Those with similar illness severity but with underlying chronic comorbidities may be admitted for observation and possible management of deterioration of their chronic disease. Those with more severe presentations, such as pneumonia, respiratory failure, ARDS or shock, will almost certainly require admission. The most common features in the clinical history are that of fever and cough, which is typically continuous and dry. Having said that, up to a third of patients may present with sputum production, which may be linked with underlying comorbidities or superimposed bacterial infection. Other constitutional symptoms such as myalgia may exist, and upper respiratory symptoms of rhinorrhea and sore throat, while less common, do not rule out COVID-19. Of note, a minority of patients have GI symptoms that may be associated with viral production in the GI epithelium. The majority of patients show mild self-limiting disease only, with 15% progressing to more severe disease typically within 5 to 12 days of the onset of mild symptoms. This becomes much more common in those with chronic comorbidities, including all types of diabetes, chronic respiratory problems, chronic cardiovascular problems including hypertension, and significant immunosuppression. Of note, the average delay from symptom onset to hospital admission is 7 days, to development of ARDS is 8 days, and to ICU admission is 10 days. What this means is that the majority of patients who do deteriorate will do so early in their hospital admission, and hence the importance of vigilant observation. Of those that do require ICU admission, 50% exhibit cardiac injury, renal injury or liver dysfunction, with 30% having shock or multi-organ failure, and with a 50% mortality. At the time of writing this presentation on the 25th of March 2020, NHS England recommends secondary care providers only test patients requiring hospital admission. Tests taken should include upper respiratory tract green viral swabs as a minimum, with the addition of sputum in a sputum pot if possible. Swabs may be either nasal and throat swabs in individual containers, or the same container, or a single throat then nasal swab. These samples must not be sent in the pot system due to fears of virus spreading. Blood tests for serology are only used for surveillance and not diagnosis, and should be taken in gold-topped containers. You must ensure that request forms are for viral serology or PCR specifying SARS-CoV-2 or COVID-19. Tests simply stating coronavirus are not sufficient, as many labs will only test for 4 other coronaviruses that are known to cause more mild disease. You should also consider requesting PCR from swabs and sputum for influenza and other respiratory viruses, as while positively identifying other viruses does not rule out COVID-19. Co-infections are common. A negative PCR does not rule out COVID-19, especially if the source is a nasopharyngeal swab, where sensitivity for throat swabs may be as low as 92%. Bronchoscopy for bronchoalveolar lavage, while more sensitive, should not be performed to rule in or out COVID-19, as it risks patient deterioration and greatly increases exposure to the healthcare team and will not alter patient management. It may, however, be required in indications where it would otherwise be performed, such as in immunosuppression where there are concerns of a fungal pneumonia. Routine baseline investigations should be performed, including observations and blood sugars. FBC may be unremarkable, with lymphopenia being common, as well as mild thrombocytopenia. More significant thrombocytopenia with platelet counts of less than 100 are less common, and alongside other coagulation dysfunction, including DIC, are associated with a poor prognosis. Baseline renal function and liver function tests should be performed, and the use of CRP has been shown to be both prognosticate, and monitor disease severity and progression. Procalcitonin is often normal and may be raised in bacterial causes of pneumonia, but its routine use in clinical practice is not recommended by NHS England. Arterial gases should be performed in any hypoxic patient and blood cultures taken for pyrexial patients. NHS England suggests imaging for unwell patients with suspected COVID-19 to include patients with saturations of less than 94 or less than 90% for COPD, or with a NEWS of greater than 3. For patients who are otherwise well, chest X-ray may be used if otherwise clinically indicated, such as based on clinical examination findings. Cross-sectional evaluation of the thorax has increased sensitivity, but its use largely does not alter patient management. However, its use is recommended by NHS England and the British Society for Thoracic Imaging for patients who are unwell, as earlier described, with equivocal or normal plain film imaging. Its use may also be of benefit in monitoring of disease progression and/or recovery. While all cases are reported to Public Health England, there are specific circumstances when the local Public Health England health protection team should be informed. This is for confirmed cases for patients admitted from long-term healthcare facilities or prisons, or in relation to an in-hospital outbreak. Public Health England also state reporting for any other unusual scenario, which I will leave to the listener's interpretation. Patient management is largely supportive with limited evidence for any specific interventions. That is to say that patients require monitoring, correction of abnormalities, plus organ support where required. Initial oxygen supplementation during initial assessment may be required. Fluid resuscitation should be used with caution, as patients are rarely hypovolemic or shocked on presentation, and the most common cause of death is ARDS, which may be worsened by fluid overload. However, if there is clinical or biochemical evidence of hypovolemia or ongoing fluid losses, then IV fluid resuscitation may be required. Antibiotics are recommended at presentation as bacterial co-infection is common, be that primary or secondary, and may be reviewed following results of viral PCR or sputum MCNS, blood cultures, or other cultures, and may be guided by input from microbiology. Notably, there is no predilection for particular secondary bacterial infection in COVID-19 patients. Delayed bacterial infection may emerge particularly in ventilated patients and should be managed as per trust guidance for any other ventilator-associated pneumonia. With regards to antiviral therapy, their routine use is not currently recommended by NHS England. While there is some evidence they may decrease viral load, there is limited evidence to suggest they improve morbidity or mortality. This is an ongoing area of research, and I would encourage keeping up to date with the literature and discussing with your team if there is any new or promising evidence. Kaletra, a combination drug of two protease inhibitors, lopinavir and ritonavir, has previously shown benefit in the SARS epidemic when used early in high-risk patients rather than as a rescue therapy. However, it has not shown benefit in severe COVID-19 disease. Remdesivir is a nucleotide analogue that has shown benefit in vitro against the virus causing COVID-19 and in animal models of SARS and MERS. It is currently part of several randomized controlled trials. Oseltamivir and other neuraminidase inhibitors have no effect on SARS-CoV-2, but may be used where viral pneumonia due to influenza is suspected or confirmed. The use of corticosteroids is not recommended for COVID-19 or ARDS, and in fact it may worsen the prognosis. Its use, however, may be beneficial for other indications such as exacerbations of COPD. The use of chloroquine has been reported to reduce disease progression and symptom duration, however, from unpublished data. It is included in the treatment guidelines for China's National Health Commission. Nonetheless, it remains unlicensed in the UK for COVID-19 related disease, pending results from further trials. The media has reported some interest in ACE inhibitors and angiotensin receptor blockers, with reports of increased risk of complications of COVID-19 disease. The evidence for this is weak, and it is likely that patients taking these medications have increased risk to COVID-19 due to their underlying health conditions. The Renal Association UK does not recommend routine stopping of these medications on admission, which itself may lead to complications, confusing the picture between primary cardiovascular deterioration or COVID-19 related disease. If, however, there are any other indications to stop these medications, such as acute kidney injury or hypotension, then they may be held. Similarly, the recommendation against NSAIDs comes from anecdotal reports of young patients who have received NSAIDs developing severe disease. At present, the NHS position is to avoid NSAID use where possible, pending further evidence. A cohort of COVID-19 patients will go on to develop respiratory failure or multi-organ failure that may require ventilator and other organ support in the ICU setting. A number of you may find yourselves working in unfamiliar environments to care for these patients. Therefore, this section of the presentation aims to guide you to some of the interventions and clinical decisions that may be made to manage such patients. The onset of respiratory failure may be insidious, and shortness of breath may not be clinically apparent. If there is evidence of low oxygen saturation, then perform and be guided by an arterial blood gas. Now, for a brief reminder of diagnosing respiratory failure. Hypoxia, defined as a PaO2 of less than 8 kilopascals, is diagnostic with or without hypercapnia. And in practice, type 1 or type 2 respiratory failure often coexist. The need for mechanical ventilation, be that invasive or not, will depend on failure to improve hypoxia or worsening hypercapnia in response to supplemental oxygen therapy. Patients should be managed and/or resuscitated as per an AT approach, and may go on to require ICU support. The mechanism and delivery of ventilation is complex, and a senior clinician who is competent in the administration and monitoring of ventilated patients should make these decisions. However, there are some principles that are useful to understand, and the risks of droplet and aerosol generation for different techniques may blur this picture. NIV, in the form of CPAP, may be of clinical benefit. However, NIV is an aerosol generating procedure. However, there is limited data to assess its risk of SARS-CoV-2 transmission or to compare this with high-flow nasal oxygen. In practice, leakage around the mask in NIV is common, and this may increase the risk of transmission. In theory, OptiFlow poses a higher risk as these circuits are leaky. While NHS England does not impose a ban on NIV in COVID-19 patients, it does recommend the use of invasive mechanical ventilation if it is appropriate over NIV. It also recommends the use of NIV over OptiFlow due to improved safety profile and reduced oxygen consumption. NIV may, however, be used, for example, in situations where this is the patient's scene of care, or invasive mechanical ventilation is not appropriate. If NIV is used, patients should be in a negative pressure room where possible, and staff should use full PPE precautions including FFP3 face masks and long-sleeved gowns. In terms of invasive ventilation in ICU, this is delivered via an endotracheal tube or tracheostomy if ventilation for more than 1 week is anticipated. Data from China suggests that the normal range for ventilation for COVID-19 patients is 1 to 2 weeks. Ventilation can largely be split into pressure cycled or volume cycled. In pressure cycling, gas is delivered until a set pressure is reached and expiration takes place with passive recoil. This has the advantage of reducing peak airway pressures, which may be useful in ARDS. However, if compliance decreases, tidal volumes will fall and patients risk developing hypoventilation, so this must be carefully monitored for. In volume cycling, a predetermined tidal volume is administered and then held before allowing elastic recoil. This is generally split across inspiratory time at a ratio of 30 to 10 to 60. COVID-19 is a risk factor for the development of ARDS that is characterized by injury to the alveolar epithelium and endothelial barriers with the formation of non-cardiogenic pulmonary edema. It is characterized by respiratory failure with a known risk factor, such as COVID-19, with a PaO2 to FiO2 ratio of less than 40 kilopascals and bilateral infiltrates on chest X-ray. It needs to be differentiated from cardiogenic pulmonary edema either clinically or with the assistance of a pulmonary capillary wedge pressure of less than 19 millimeters mercury. The management depends on the severity and can be appreciated in this table, showing the Faculty of Intensive Care Medicine guidelines. General principles include the use of low tidal volumes, less than 6 mL per kg of ideal body weight, with plateau pressures set below 30 millimeters of mercury. Meta-analyses has shown a conservative fluid balance may be beneficial over liberal ones without evidence of harm. This typically involves fluid input only through administered medications and NG feeding without the need for maintenance fluid. If hypovolemia is identified, then 250 ml boluses of plasmolyte may be used. Septic shock is not a common feature of COVID-19. However, low doses of noradrenaline may support the hypotension of deep sedation. Positive end expiratory pressures may help small airways open during elastic recoil, and higher levels are recommended for moderate or severe IRDS. In cases where PaO2 to FiO2 ratio is less than 20 kilopascals, neuromuscular blockage with cistacurium may be used as well as prone ventilation. Turning a sedated and paralyzed patient may be beneficial, but does pose hazards both to the patient and to healthcare workers. You should receive training before being asked to assist with this. Finally, for cases of severe ARDS, a referral to the nearest ECMO centre may be required. The use of inhaled vasodilators such as nitric oxide has not been shown to be beneficial in ARDS, and the use of high-frequency oscillation ventilation may indeed be detrimental. Alongside these interventions, you may see other supportive treatments for intubated patients. All intubated patients will have an NG cited to aid in meeting their patient's nutritional requirements, and patients are typically sedated with propofol and fentanyl for their safety and comfort, and at regular intervals, patients should have their level of sedation assessed by an agreed scale, such as the Ridgmond Agitation Sedation Score. Temporary sedation holds may also be used. Increased agitation may cause coughing and tube biting, which are both dangerous for the patient and may be managed by temporarily paralyzing the patient using 50 milligrams of rocuronium. Successful extubation requires optimization of the patient's respiratory functions, and slightly lower targets than normal for FiO2 and PEEP may be required for successful extubation in these COVID-19 patients with ARDS. The development of multi-organ failure is possible with COVID-19 and, as expected, is a poor prognostic indicator. Septic shock, as discussed, is not a common feature, but there have been reports of myocarditis and other cardiomyopathies in COVID-19. Elevated troponin levels may be an indicator of this and do correlate with mortality. Renal replacement therapy may be required in those showing significant renal injury. These certainly are testing times for the NHS as a whole, with a requirement more than ever on teamwork, leadership and professionalism. A global pandemic will put a strain not only on resources, but also on individuals within your team. It is important that we support each other during this time and look after our own health and the health of our colleagues. With a similar respect, family and friends of patients are likely to be increasingly concerned, with patient visiting being very limited. Healthcare workers' input to communicate to friends and relatives of patients will be extremely invaluable during this time. Discussions regarding ceiling of care need to be made as early as possible in the disease course. Limitations in resources and its distribution are likely to have an increasing impact on patient care and will really put pressure on our ethical principles. Discussion with family, friends, and colleagues or seniors need to be carried out sensitively and documented carefully. Management of COVID-19 patients is an area of active research and is an area of interest to the wider scientific community, the government, and indeed the public. As further studies are completed, then the evidence may change, and it is important to keep updated during this time. However, most importantly, keep safe.